Welcome to the ISTH webinar series. I'm Jeff Weitz, and I'm a clinical hematologist and professor of medicine and biochemistry and biomedical sciences at McMaster University. I will be moderating today's webinar. Dr. Jean Connors and Dr. David Gailani will be discussing the factor 11(a) inhibitors, factor 11(a) as a target for anticoagulation, the what, why, and how. So these are the learning objectives. We're going to discuss how 11(a) inhibitors may meet the unmet needs for anticoagulation. We'll explain the differential role of factor 11 in hemostasis and thrombosis. We're going to compare the key aspects of current factor 11 and 11(a) inhibitors in clinical trials, and we're going to briefly review the results of the clinical trials available to date. I'm going to start with the unmet needs for anticoagulation to set the stage for why we need new anticoagulants. Next slide, please. So here I provide you with a timeline of anticoagulation therapy through the years. And I want to point out that it's been about 15 years since the current direct oral anticoagulants, dabigatran and the 3 oral factor 10A inhibitors, were introduced onto the market. And although these agents are marked advance over vitamin K antagonists like warfarin, there still are problems. Remember that the ultimate goal of anticoagulation therapy is to attenuate thrombosis without increasing the risk of bleeding. And although the DOACs, the direct oral anticoagulants, come closer to this goal than vitamin K antagonists, there's still a problem, and that's the high rates of major and clinically relevant non-major bleeding that could be as high as 20%, not in the phase 3 trials, but in the observational studies in the elderly atrial fibrillation population. So safety is still an issue. So bleeding, or the fear of bleeding, has led to the systemic underuse of anticoagulants for stroke prevention in atrial fibrillation. And it's estimated even in the most recent registries that at least 30% of eligible atrial fibrillation patients are not getting anticoagulation. And even when the direct oral anticoagulants are prescribed, in at least 25% of patients, there's the inappropriate use of the lower dose regimens. And both of these problems lead to underprotected patients or unprotected patients. Next slide. Now, I remind you that coagulation can be activated via 2 pathways. There's the tissue factor-driven extrinsic pathway. This is the pathway that's initiated when atherosclerotic plaques rupture, for example. And there's the contact-driven intrinsic pathway. This is the pathway that's initiated when blood comes into contact with foreign surfaces, such as mechanical heart valves or stents. Now, the current anticoagulants all target clotting factors in the common pathway, either factor 10A or thrombin or both. Interest has moved upstream to the intrinsic pathway with a particular focus on factor 11. By targeting factor 11, the promise is to attenuate thrombosis without disruption of hemostasis and getting us closer to that holy grail. Now, most of the attention is on factor 11, and the evidence supporting factor 11 as a target comes from a number of different areas. First, persons with congenital deficiency of factor 11 are protected from thrombosis, but rarely experience spontaneous bleeding. Second, large genetic epidemiology studies show that The risk of thrombosis is twofold higher in subjects with high factor 11 levels compared with those with normal levels, and 40 to 50% to 90% lower in those with reduced factor 11 levels, and yet persons with reduced factor 11 levels rarely have spontaneous bleeding. And finally, in animal models, whether in rodents or even in non-human primates, if you inhibit factor 11 or knock it out, you attenuate thrombosis, but there's no bleeding. And this is different than what was seen in animal models with the DOACs, whereas increasing doses, more attenuation of thrombosis, but increasing doses also led to more bleeding. Next slide. So there are different strategies to target factor 11. We can use antisense oligonucleotides to reduce the hepatic synthesis of factor 11, antibodies that bind to factor 11 and either block its activation or block its activity or do both. And finally, we have small molecules that, like the DOACs, bind reversibly to the active site of factor 11A and block its activity. Now I'm going to turn over to David Gailani. He's a professor of pathology, microbiology, and immunology, and professor of medicine in the Division of Hematology Oncology at Vanderbilt University Medical Center, and the Ernest W. Goodpasture Chair in Experimental Pathology for Translational Research at Vanderbilt University. Dr. Gailani will be discussing the differential role of factor 11/11A in thrombosis and hemostasis. Dave?
Thank you very much, Jeff, and good morning, everybody. Now, I hope I have control of the animation here. That'll just make it easier. My goal today, as Jeff pointed out, is to discuss factor 11 and factor 11A, how we currently think of them as contributing to hemostasis, and how their roles in thrombosis may differ from those in hemostasis. And if you'll bear with me, I'm going to go back to the beginning. Not very quickly, though. Can you advance the slide for me, please? To the discovery of factor 11 back in the 1950s by Robert Rosenthal, he identified 3 members of a family who had some relatively mild bleeding disorders, primarily bleeding with dental procedures and heavy menstrual bleeding in women. And surprisingly, these individuals had a very, very long clotting time in the equivalent of the PTT that was being used back in 1953. And because of this, their condition was dubbed a hemophilia-like bleeding disorder because the pattern on the PTT assay looks somewhat like that in factor 8 deficiency and factor 9 deficiency. In fact, the bleeding, the prolongation of the clotting time was even greater in these particular individuals that he was studying than in people with hemophilia. But it was quite clear that from a symptomatic standpoint, the bleeding was milder. It typically required trauma. It was not spontaneous, and the nose and oropharynx seemed to be primarily involved. Subsequent studies of additional people with this condition also show that the urinary tract was susceptible. Injury to the urinary tract caused excessive bleeding. Can we go to the next slide, please? So in 1964, the position of this protein, now called factor 11, in the coagulation cascade was first reported. The series of reactions you see here are those that occur in the activated partial thromboplastin time we still use today in clinical laboratories. And in this particular model, factor 11A is a key link in the process, and deficiency of the protein causes a marked prolongation of the PTT. In this particular assay, the factor 11 is activated by a process called contact activation. And if you look over here on the right, in the little gray cloud, what happens in a PTT assay is we usually put a surface into the plasma, and this results in factor 12 and a protein called prekallikrein activating each other. And once you get enough activated factor 12, that's going to activate factor 11 and and generate thrombin generation and clot formation through the cascade. Factor 11, in fact, is a homologue of prekallikrein. It looks very, very structurally similar to it. The protein actually arose from a duplication of the prekallikrein gene. Now, to the credit of the people who devised this scheme back in 1964, they realized that there was something not quite right with it when it came to explaining hemostasis. So for instance, we know that factor 9 and factor 8 deficiencies cause a significant bleeding disorder. Factor 11 deficiency, however, is often asymptomatic, and if it does cause symptoms, they're different from those in hemophilia and are generally mild. And then, of course, patients missing these contact phase proteins up here don't have a bleeding disorder at all. So while this is a useful assay for the clinical laboratory, we're not really capturing what factor 11 does when we look at this model. Next slide, please. So in our current understanding of hemostasis, thrombin generation for preventing bleeding, what's shown over here on the left-hand side is the mechanism for generating thrombin that is present in almost all vertebrate organisms. It involves actually, when at the site of a wound, factor 7A forming a complex with tissue factor, and then activating factor 10 and 9 to sustain thrombin generation. All of the proteins in this box are critical for normal hemostasis. If you are complete deficiency of any one of these proteins either causes a severe bleeding disorder in the case of factor 9 or 8 deficiency, and in the case of the other proteins is probably not compatible with life. I should point out that for the last 70 plus years, this system in the thrombin generation box has been the target of our anticoagulation therapy. And of course, this is why anticoagulation therapy compromises hemostasis. The contact system, which is represented by the box over on the right, is found in land vertebrates. And in most of them, interestingly, there's no direct connection between that system and the thrombin generation mechanism. It's only in mammals where we have a duplication of prekallikrein giving us factor 11, which can be activated by the factor 12A and sustains clotting, or contributes to clotting through activation of factor 9. Now, we know that patients lacking contact proteins don't bleed excessively. So this suggests factor 11 can be activated by other mechanisms, and that would be needed to explain the bleeding propensity we see in some patients with this disorder. Factor 11 can auto-activate itself. Thrombin generated early in the hemostatic process can also activate factor 11. So this system with factor 11 can operate independently of contact activation. And that's an important distinction from the older model. It's important also to remember that factor 11A is a kallikrein-like model. And as such, if I can have the next slide, and this may require, yeah, here we go. Great, excellent, thank you. It can also activate factor 12A. And in some models of sepsis in mice and in primates, we actually see evidence that inhibiting factor 11 somehow seems to shut down contact activation. So our current understanding of factor 11 has morphed from a component of the intrinsic pathway of coagulation necessary for generating thrombin in a PTT assay to one where it's really an ancillary protein in hemostasis, but really probably functions as a bidirectional nexus, allowing the thrombin generation mechanism, contact activation mechanism, and other mechanisms to interact with each other. Certainly, you can get thrombus formation through contact activation mediated activation of factor 11 in situations such as renal dialysis or cardiopulmonary bypass, or in patients with indwelling catheters where an artificial surface allows contact activation to occur. But the 11 can also independently function independent of the contact activation mechanism, which would explain the bleeding disorder in factor 11 deficient patients compared to no bleeding disorder in patients with factor 12 deficiency. And also, I think, would explain some of the findings in Jeff alluded to regarding thrombosis, where factor 12 deficiency does not seem to have as big an effect on disorders like venous thrombosis, ischemic stroke, and myocardial infarction compared to factor 11. Can I have the next slide, please? So what I'm going to do here is I'm just going to sum up a huge amount of work, mostly in preclinical models, suggesting how factor 11's role in hemostasis may differ from that in thrombosis. And there's a lot of animation here, so I'm going to be asking you to click a lot, and I apologize that. But what we have here is a schematic where the endothelial cells of a blood vessel are shown in yellow, and the tissue factor bearing cells, which are going to be the triggers for clot formation, are underlying that, separated from the components of the blood, which is going to be in the lumen. If I could have the next couple clicks. One more, please. A hemostatic clot primarily forms within a blood vessel wall and extravascularly. And it appears from examining patients with factor 11 deficiency that factor 11 is not needed in most situations to form a hemostatic clot. These patients seem to require 11 when injury occurs in the oropharynx, nasopharynx, urinary tract, possibly because high fibrinolytic activity tends to break down the clots. But for the most part, 11 is not really a major component of this system. Contrast that with what might happen in thrombosis. If you can click, give a couple clicks. If we have some kind of a disease process involving endothelial cells, or an injury in an animal model would be the equivalent, you start to see some accumulation of platelets and fibrin on the surface of the blood vessel, and that really isn't affected all that much by factor 11 deficiency or factor 11 inhibition. However, next, if you could click again. One more click, please. Thank you. As the back one, please. I'm sorry. As the vessel becomes narrowed and shear forces increase, factor 11 seems to be important for sustaining the three-dimensional growth of the clot into the lumen, something that's not necessary, obviously, in a hemostatic clot. And so in factor 11 deficient animals, or in animals that have been treated with a factor 11 inhibitor, what we often get with vessel injury is accumulation of some clot on the surface of the vessel, but any clot that tries to grow into the lumen of the vessel starts to fragment, and it maintains the patency of the vessel. One last click, please. And so this portion is 11 dependent. And so one might be able, by inhibiting 11, to prevent this. And this seems to be something that factor 11 is very important for, without compromising hemostasis, where factor 11 is only needed in certain situations. And my final slide here is just giving you one example of data from animals to try to give you the impression that it may be possible to separate an anti-thrombotic effect from an anti-hemostatic effect by targeting factor 11. So what we're looking at here are results of a mouse carotid artery occlusion model where we use ferric chloride to produce an injury in the endothelial cells. And if we take groups of 10 mice and we expose them to different concentrations of ferric chloride, what you see is a 2.5% ferric chloride concentration. The subthreshold and the vessel remains patent, but as you increase the ferric chloride concentration, you eventually shut off the vessel with a thrombus. And we can also look at bleeding with a simple tail bleeding time. Mouse will bleed for about 200 to 250 seconds in such a model. If we go, can I have the next click, please? If we go and give this animal a bolus of heparin, we see that we have to increase the ferric chloride concentration substantially in order to get a clot. That's the antithrombotic effect of the heparin. But that comes at a cost, of course. We see that the heparin causes severe bleeding. And in fact, these animals will exsanguinate if you don't cauterize their tails. And if we actually take a defect in the core mechanism for hemostasis, factor 9 deficiency, next click, please, we see a very similar phenomenon. Resistance to thrombosis, but at the cost of increased bleeding. If, however, we use factor 11 deficient mice, final click, we get a comparable effect on thrombus formation. Thrombi start to form, but they can't ever actually completely occlude the vessel. But we don't see a hemostatic abnormality in factor 11 deficient mice. And interestingly, not only in mice, but other animals that have been used in preclinical studies, complete deficiency of 11 or severe marked inhibition of factor 11 hasn't convincingly produced a bleeding phenotype. So this just is an indication that maybe it's possible to separate bleeding and thrombosis by targeting factor 11. And I will stop there. Thank you for your attention.
Thank you so much, Dave. As a reminder to the audience, first, we're going to take questions at the end of all the presentations. So please submit your questions, not in the chat, but in the Q&A box at the bottom of your Zoom screen. Next, we will have a presentation from Jean Connors, who's a professor of medicine at Harvard Medical School. And she's a hematology attending at the Brigham and Women's Hospital and the Dana-Farber Cancer Institute, and also the medical director of the Anticoagulation Management Services and the Hemostatic Antithrombotic Stewardship Program. Jean will talk to us about the current status of factor 11, factor 11A inhibitors in clinical trials. Please go ahead, Jean.
Thanks, Jeff, and thanks, Dave, for great presentations. I believe I have control of the slides, but maybe not. Can you advance, please? So I'm not going to go into detail that Jeff elegantly described about the classes of inhibitors that we have for factor 11, 11A. We have 3 classes. I am going to discuss in some greater detail results from phase 2 and phase 3 trials for the monoclonal antibody abelacimab and the small oral molecule reversible inhibitors asundexian and milvexian. I'm going to first cover the phase 2 TKR. This is total knee arthroplasty or total knee replacement trials. These are often done. It's an elegant way to do dose finding studies and get proof of concept for both efficacy and bleeding, because unlike other clinical trials, you can get results from each participant within 10 to 14 days, and you can assess for VTE or lack of development of VTE. So very fast and elegant model to get data. There are phase 2 trials for other indications that also use dose finding strategies and looking for safety and efficacy in different trial designs in end-stage kidney disease, stroke, acute coronary syndromes, MI, and particularly AF, which is going to be the focus of this presentation. Now, whoops, sorry, I think we both advanced. Go back, please. So this is a meta-analysis of the data from the phase 2 TKR trials, and I do not need to go into detail to show or discuss all the different trials because it's clear from this forest plot that the results for both preventing VTE and for decreasing clinically relevant bleeding favor the factor 11 inhibitors, whether it's the antisense oligo, monoclonal antibodies, or milvexian in these trials. Compared to enoxaparin, there was a significant decrease in both VTE development and clinically relevant bleeding, which is surprising because enoxaparin is the gold standard and is considered to have low risks of both. Next slide, please. And so this slide summarizes the phase 2 trial data that we have to date. All of the results that are shown here have been published. The abelacimab Azalea TIMI 71-AF trial, the manuscript is currently in review, but we expect it out soon. And so asundexian has the Pacific suite of trials, and they looked at asundexian in secondary stroke prevention, in acute MI, and atrial fibrillation. And you can see that a variety of different doses were used for secondary stroke and AMI, with the comparator placebo for both of those groups on a background of dual antiplatelet or single antiplatelet therapy. Milvexian in the axiomatic secondary stroke prevention trial looked at 5 different doses of milvexian versus placebo with SAPT-DAPT. And these results have been published as well. And I'm going to discuss briefly in the next slide the abelacimab Azalea TIMI 71-AF trial, which was a phase 2 trial looking at 2 different doses of the monoclonal antibody abelacimab compared with rivaroxaban in patients with atrial fibrillation. Now, I'm focusing on AF trial results. Given the global burden of AF, it is projected that in the year 2030, at least 35 million people around the globe will have atrial fibrillation. We also have comparison with an active comparator drug for these, unlike placebo comparators with backgrounds of SAPT or DAPT, which may be a little more difficult for those of us who do anticoagulation to interpret. Next slide, please. So this is the design of the phase 2 Pacific AF study. And in this, patients with qualifying atrial fibrillation characteristics were randomized to 2 different doses of asundexian, the oral small molecule inhibitor, in a multi-center randomized fashion, with the primary outcome the composite of major bleeding or clinically relevant non-major bleeding according to ISTH criteria. And these were compared to apixaban in about 250 participants per arm and over a short 12-week duration of study. Next slide, please. And these are the results from the primary outcome, the incidence of bleeding in the specific AF trial. And you can see the blue is the lower dose, 20 milligrams of asundexian. The gold is the 50 milligram dose. Gray are the pooled results. And apixaban 5 milligrams twice a day is in the green. And you can see that bleeding rates are lower. The events are lower in the asundexian arms compared to abelacimab. Now, secondary outcomes were the composite of these bleedings, which you see major and CRNMB on the left, minor bleeding and all bleeding. And in all cases, asundexian performed better with decreased bleeding events compared to apixaban. It should be noted that 3 ischemic strokes were seen in the pooled asundexian arms and no stroke in the apixaban arm. But remember, this was a 12-week observation. Next slide, please. The Azalea phase 2 trial study design is very similar with just under 1,300 patients with AF with similar moderate to high risk stroke characteristics. And these participants were randomized to the 2 different doses of abelacimab, as I discussed, compared with rivaroxaban. This was an event-driven study with the primary endpoint major or clinically relevant non-major bleeding. This trial was stopped early by the IDMC, the Independent Data Monitoring Committee. And if you look at the next slide, you will understand why this trial was stopped. In this trial, you can see from the plot of a major or clinically relevant non-major bleeding on the y-axis in days that both doses of abelacimab were had a much lower risk, over 60% risk reduction and even greater in bleeding compared to patients treated with rivaroxaban. And so this caused this dramatic graph caused the IDMC to stop the trial early, and we are waiting for publication of these results. Next slide, please. And so here's where we stand today with ongoing phase 3 clinical trials with the factor 11A inhibitors. We have 3 trials looking at the monoclonal antibody abelacimab. The first listed is in atrial fibrillation patients whom the treating clinician has determined that they are unsuitable for oral anticoagulants, either warfarin or DOAC, primarily because of bleeding risk. And in this, interestingly, the comparator is placebo, as the clinicians elected not to treat, aiming for about 1,900 participants. There are 2 cancer-associated VTE trials using abelacimab. In one, the comparator is apixaban, and in the other are patients with GI and GU tract malignancies which are known to have an increased risk of bleeding with the DOACs, and the comparator is dalteparin. I'm going to skip over asundexian for a minute and go to milvexian. Large suite of trials in the Librexa trials cohorts with atrial fibrillation being compared to apixaban, the stroke, secondary stroke prevention being compared to placebo, but on a background of antiplatelet therapy, and the same with acute coronary syndromes, adding on milvexian to placebo and the standard of care treatments for ACS and PCI. Now, the reason I skipped over asundexian is that there are two trials going on with this oral small molecule inhibitor, and one was stopped in November, the OCEANIC-AF, and I'm going to discuss those results, but this was stopped by the IDMC because asundexian was found to have less efficacy than the comparator apixaban. I should note, and you're going to hear me say this a couple more times in the next few minutes, that the IDMC determined that the OCEANIC stroke trial should continue. And because of these results from OCEANIC-AF, all of these other trials, the IDMCs have met since the halting of the trial and have determined that it's safe for these trials to continue, including the milvexian in AF trial. Next slide, please. And so this is the trial design for OCEANIC-AF, similar trial design, patients with high risk moderate to high risk AF characteristics as described in this box here, randomized to oral asundexian or apixaban for a minimum of 9 months, with the primary outcome time to first occurrence of stroke or systemic embolism, and the primary safety endpoint being ISTH major bleeding. Next slide, please. As noted, and as I discussed, OCEANIC-AF was stopped early due to lack of efficacy. And as I will repeat again later on, OCEANIC-STROKE was determined to be able to continue in this population. Next slide, please. And so these are the results of the OCEANIC-AF trial. They were just published in the New England Journal online on September 1st. And on the left-hand panel, we have the primary efficacy endpoint, and the goal was to prove non-inferiority. But again, trial was stopped because asundexian use resulted in a higher rate of stroke or SSE compared to apixaban with a hazard ratio of 3.8 essentially, and you don't even need to look at the hazard ratio to see that magnitude of difference. And on the right-hand panel, we have ISTH major bleeding, the primary safety endpoint. And in this trial, they were going for superiority if the trial had gone to completion. And you can see that there is decreased risk with asundexian, but given the primary outcomes, it's not clear how to interpret this. Next slide, please. And so there's been a lot of chatter about OCEANIC-AF and what does it mean for continued development of factor 11A inhibitors. Is it just that the 11 inhibitors have inferior efficacy compared to DOACs, or is there something about the dose or the trial design with asundexian that's responsible for these results? Some have tossed around the idea that maybe this is a class effect and factor 11 inhibitors may not play a role in the development of thrombosis and atrial fibrillation. However, trials of the other factor 11, 11A inhibitors, including for AF and including the milvexian AF trial, the XIa-AF, are continuing after recent reviews by the IDMC. So it seems that it's unlikely to be a class effect. Specific characteristics of asundexian. We look at the dose and how the dose was determined, and also the pharmacokinetic pharmacodynamic data. So asundexian was shown to reduce the factor 11A activity by greater than 90% following doses at peak and trough, but they used an assay that is not used clinically, a non-standard assay for inhibition of 11A activity. There are no correlates with the APTT, which we are all used to, and which is what we use clinically to help identify patients with congenital factor XI deficiency. And so it's not clear how the results of this assay actually translate into in vivo activity. There are also some data that were published in August looking at effects on thrombin generation, and in which the in vitro assays replicated the expected doses with asundexian and with milvexian in these thrombin generation experiments, and found that there was less inhibition of thrombin generation with asundexian than with milvexian. Now, this may be because the inhibitory concentration, the kinetic parameters for inhibiting factor XIa, as shown at the bottom of this slide, differ by a factor of 10-fold, with milvexian having a higher affinity and a lower inhibitory concentration. Next slide, please. And so we look at going back to the TKR trial data, and that's what this is, looking at the dose finding studies, remembering that 40 milligrams of enoxaparin is a prophylactic dose. And so we're looking for a dose that significantly suppresses venous thromboembolism in the TKR model. And you can see where the red arrow is that the dose that was selected for the AF trials is the 100 milligram twice a day dose to get almost maximal suppression for the dose finding studies, not very different from the 200 milligram results, but significantly better than with enoxaparin. Next slide, please. And so this is a comparator chart looking at dose selection for the phase 3 trials, the XIa-AF and OCEANIC-AF trials. Dose selection key. And we can see that the milvexian team did a 16-fold difference in dose for dose ranging studies to hone in on the dose that should be used, whereas OCEANIC-AF may not have covered the same ground and same breadth of dosing to settle on the dose. The axiomatic TKR trial, which I stumbled on before, it was actually not a secondary stroke prevention. That was a typo in a previous slide. It was a TKR trial, a clear dose response, but also some hints at efficacy. This was not done. A TKR trial was not done in OCEANIC AF. There were safety outcomes from the Pacific-AF trial. And so the basis for dose selection differed with, I think, more solid data in selecting the dose for milvexian with concrete clinical findings using the middle dose of 100 milligrams BID. Next slide, please. And so the key takeaways from this webinar should be that we think that factor XIa inhibition is a promising new anticoagulant strategy, and development is definitely continuing. There's evidence of decreased bleeding compared with the DOACs or low molecular weight heparin from the early clinical trial data, the TKR data, and data in other phase 2 trials that I did not show you. We are anticipating data from the ongoing phase 3 trials, which have not been stopped by IDMC in the wake of the OCEANIC-AF findings. We need to identify the benefit risk profile compared with the current standard of care approaches in all of these phase 3 trials. IDMC, as I've said now, I think for the 5th time, have voted to keep basically all of the phase 3 studies open. So factor XIa is definitely here. It's on the horizon, and in inhibition of factor XI and XIa may play an important role for patients with continued unmet needs, as Jeff discussed at the beginning of this presentation, as current anticoagulants are just not meeting these needs. So I want to thank you, and I'll turn it back to Jeff.
Thank you, Jean. We'll now begin the question and answer period. You still have time to submit your questions through the Q&A box, but I'm going to start with the questions that have already been submitted, and we'll try and get through as many as we can. Jean, as far as I know, the only factor 11/11A inhibitor that's being tested in patients with cancer is abelacimab, which of course is a monoclonal antibody that binds factor 11 and blocks activation and activity. Somebody asked about drug interactions with this antibody, and of course they're dialed out with the antibody, and also the antibody doesn't have any renal clearance, so that would be an advantage of the antibody over the two agents that are being compared in the Aster and Magnolia studies, either apixaban or dalteparin. So I think we've got that one. Dave, a couple of questions that I think you would be the best one to address. You showed us very nicely about the differential effect of factor 11 in thrombosis versus hemostasis, and how factor 11 is probably mostly redundant for hemostasis, but really important for thrombus growth, for intravascular thrombus growth. So somebody's asked, is it always the case that the amount of tissue factor driving the initiation of clotting is greater for hemostasis than it is for thrombosis?
That's actually an excellent question. And the answer is that they may be comparable. So the question is, why do you need factor 11 in one situation versus the other? And I think I would again point out that when we have a hemostatic clot, you have blood flowing into areas where tissue factor is relatively replete, the extravascular space within the blood vessel walls. Tissue factor is not present within the circulation. It's not normally present on endothelial cells. If it's confined just to the endothelial cells, surfaces, for instance, it's like, as it probably is in some of our models, you'll get clot formation on the endothelium. The question is, what happens as you grow away from that tissue factor source, which would probably not be occurring in a wound situation where the blood is actually headed toward the tissue factor source. And so our working hypothesis is that factor 11 activation, either through thrombin or perhaps even contact activation in some situations, is necessary because the tissue factor stimulus is being covered up by the growing clot, and the clot is moving away from that initiating source.
And just following up from your statement on factor 11 and inflammation and sepsis, someone's asked about the possibility of using factor 11 inhibitors in the sepsis setting. What would that do? And will factor 11 inhibition have any negative effects on inflammation in people who are treated?
Okay, a complex question. In the rodent and primate models that have been studied for, I would call it systemic inflammatory response. I don't know, it's not that many of them are not true. Some of them are true sepsis scenarios where you have live organisms. Some of them aren't. Inhibiting factor 11 has had a dramatic effect in certain models with certain organisms, particularly Staphylococcus in primates, and then with the cecal ligation and puncture model in rodents. And it's curious because it seems like blocking factor 11 has multiple effects on things that are, we might think, are distinct from thrombin generation, including the cytokine storm that arises, the activation of complement, the activation of the contact activation system. And so if you can get, the data would suggest if you can get the 11 inhibition in early enough, you may be able to curb some of those devastating effects. Whether or not they're going to have any effect once the sepsis syndrome has really started rolling is a different situation. In those models, we didn't see evidence of a compromise of hemostasis beyond what the sepsis was causing. Let me step back. The deleterious effects on the hemostatic system seem to be blocked by the 11 inhibition in the models that we've used. And so you don't get the impression that blocking 11 will cause, enhanced bleeding like using activated protein C might have done in some patients. So it's interesting. I mean, these are highly constrained models. How they correlate with human sepsis is not clear at this point, but it's interesting.
Yeah, I don't expect, and I'm not aware of any immune problems that have occurred in any of the phase 2 or phase 3 trial.
No,
to date.
yeah, I would say, Jeff, that there are some studies that suggest that with certain organisms in rodents like Klebsiella pneumonia, that having no factor 11 may have compromised pulmonary function, but that's just a limited set of data.
Okay, now, Gene, I think the takeaway message from your presentation is that the current thinking is that the asundexian was underdosed in the OCEANIC-AF trial, and that resulted in the failure to prevent stroke compared with apixaban. And what's important to note there is that the dose of milvexian that's being evaluated in the XIa-AF trial is fourfold higher. Plus, it's being given twice a day to minimize peak to trough variances in APTT prolongation and so on. And I think that another question was about end-stage kidney disease. There have been several phase 2 trials in end-stage kidney disease. And somebody's asking, well, why is there no phase 3 activity in that disorder? I know that there is another antibody that's being evaluated in end-stage kidney disease, a Merck antibody. The results of that trial have not yet been disclosed, but should be available soon. And it's possible that those results will prompt a phase 3 trial. So I don't think people are necessarily ignoring end-stage kidney disease and people on hemodialysis. I think it's just finding the right drug to use for that indication. Dave, a question, it's a common question, how are we going to monitor factor 11 inhibitors, or maybe not monitor, but measure their effects in the clinic?
Sure. So what most clinics, most hospitals are going to have are APTT assays. And because of the importance of 11 in triggering the APTT response, somebody who's on a high dose of one of these drugs is going to have a very prolonged PTT. But we also know that measurements of factor 11 by PTT-based techniques correlate very poorly with bleeding symptoms. And we really don't know at this point how they correlate with efficacy for thrombosis. So I guess I have two thoughts on this. One is that it may be necessary at some point, particularly for the small molecule inhibitors, to have some sort of 11A based assay that might be comparable to the 10A based assays we use to follow heparins or low molecular weight heparins, and can be used to follow DOACs, if it becomes important to know what the dose is. However, I think that the Azalea trial raises the distinct possibility that what we probably maybe should be going for with a lot of these drugs is just complete or near total inhibition of factor 11, in which case you just need something that's indicative of a strong suppression of the target, and the PTT may be useful in that regard. But it's difficult because the PTT assays vary from laboratory to laboratory, and so I mean this is an issue that really deserves some thought.
I do think that's the preclinical data that we sort of glossed over is so important, because this is how we got to the stage with DOACs, where finally doses were selected based on prior data where we don't measure or monitor and accept a wide therapeutic window. It may be, as Dave, you were alluding to, that maybe a wide therapeutic window isn't what we should be going for. It should be total suppression of 11. But once the dose is identified, we may not need to monitor for
Right.
treatment efficacy. And that
Right.
would hopefully be the goal. You know,
Right, right.
except
And don't forget, Jean, that these agents have different mechanisms. So it
yes,
may be different if you're using an agent that blocks factor 11A generation than if you're
Yes.
using an agent that just blocks the factor 11A that's already formed. Jean, we don't have a lot of time left. I'd like you to very briefly, somebody's asked about what happens if there's serious bleeding? What can we do to reverse the
Yeah, no,
factor 11 inhibitors?
it's a great question, and for the different trials, there are bleeding strategies available. You know, management of bleeding strategies. We've extrapolated for those with congenital factor 11 deficiency, and as Jeff described, these patients with activity factor 11A activity less than 1%, no detectable 11, walk around daily without bleeding. And from the data we've seen so far, it appears that the suppression of 11A results in a similar day-to-day lack of bleeding. So it's, first of all, it's going to be really rare that we develop major bleeding. Urgency, there were data just presented at ESC that we didn't have time to look at for abelacimab and perioperative management of these patients and outcomes based on bleeding risk. But if you have a patient on an 11A inhibitor that does present with bleeding, we suggest or needs urgent emergent surgery, depending on the molecule and the strategy, starting with tranexamic acid and using extremely low doses of R7A, not the type of dose you would use for a patient with factor 8 deficiency, and an inhibitor has been shown to be very effective from groups in Israel looking at caring for patients with congenital 11 deficiency.
Thank you. And Dave, I think I'm looking through questions and there's a lot of common threads here. One thread, you seem to have confused people about
Oh,
the link
great.
between factor 11 and inflammation and complement activation and making it a big player. And they're worried that factor 11 inhibition is going to affect inflammation, complement activation, and so on. I really don't think that there's any strong evidence that those are linked in humans. And so far, as I've said, we haven't seen any adverse effects that might suggest
That's right. We have seen the effects of 11 inhibitors on these other activities only in extreme situations, for instance, where we have injected heat inactivated staphylococcus into an animal and produced a condition that's going to be lethal within hours. Okay, this is not something that we have any evidence occurs in somebody who's receiving the drug for atrial fibrillation or something like that. Okay.
Right. And I guess the other point too is that although the APTT can be prolonged in this situation, there's a dissociation between the extent of prolongation of the APTT and the risk of bleeding. That's the bottom line with factor 11 inhibition. So somebody's asking, well, if you do a first in human study and you see a prolonged APTT with a long-acting agent such as an antibody, is this the doom for that thing? And the answer is no, because there may be no associated increased risk of bleeding. There are CME credits that are possible to obtain through that QR code that you will have in the presentation. The webinar recordings are available on the ISTH Academy for you to reference. And you can also check isth.org for more information, and you can register there for our next webinar. Once again, thank you for our supporters for funding this educational initiative. We couldn't do it without you, and I want to thank the audience and thank our speakers. Thank you so much, Jean and Dave. It's been a pleasure.
Thank you.
Thanks, Jeff.